We can start. Start.
A very warm good evening to all the respected dignitaries, faculties, and my dear postgraduates. I, Dr. Nandini, welcome you to today's ISA National PG online class. These classes are held every Monday, where certain interesting and exam-oriented topics are discussed for the benefit of our postgraduates. Likewise, today we shall discuss about the approach to an acute gastrointestinal bleed, followed by a talk on thromboelastography and its clinical application. But before we start our session, let's first invoke the blessings of Ma Saraswati by listening to the Saraswati Vandana. After having invoked the blessings of Ma Saraswati, now may I request our ISA National Honorary Secretary, Sir, Dr. Sukhminder Baji, Sir, to kindly speak a few words before we start our session.
Thank you, Dr. Nandini. Actually, now we have started a different topics. Last time we have covered, last few times, all the topics related to the pain, acute and chronic pain. Now moving towards the critical care, I think not just entirely critical care, many times in our practice, in our institutions, we do encounter the patients with a severe upper GI bleed and maybe coming with the history of melena and so many comorbidities associated with the GI bleed. So all the more it's become very challenging. It's the parts of internal medicine intensive. The intensivist has to play a role. The exact comorbidity may not be amenable to treatment with presence of anesthesiologist, but these patients may require so many interventions. Right from I think Dr. Alka will be discussing because these nowadays these type of cases are managed by the emergency medicine, the first responder in the hospital. Almost every institution now has got an emergency medicine department. Similarly, going forward, then about the with the season coming with the dengue fever and so many other diseases where the platelets transfusion, platelets infusion, and so many other viral illnesses where you see the transfusion of platelets. But when and how much the number that I think will be discussed today because those have many people have doubts about those. So one of the most important tests is the thromboelastography, where you can easily know the functional platelets in vivo. So I think without wasting time, we should proceed forward and listen to the very good classes today. So Nandini, back to you.
Thank you so much, sir, for your words. Now, may I request my co-screen coordinator, Dr. Deepika Lakshmi, to come over and introduce our esteemed faculties for today's session.
Thank you, ma'am. Good evening, all. I'm Dr. Deepika Lakshmi from Melmarutu, Tamil Nadu. I would like to introduce the faculties for today's class. Dr. Alka Verma, who's an additional professor emergency medicine at SGPGIMS Lucknow. Her areas of interest as a course director of Pulse, which is a proactive ultrasound in life-saving emergencies. As an awards, she has done a fellow of the Academic College of Emergency Experts in India. She has 22 publications, 4 intramural and 2 extramural. Welcome you, ma'am. For the second class, we have Dr. Gokul Krishnan, who's a senior resident at the Department of Anesthesiology in KMC Manipal. His specialty of interest is chronic pain and he has 1 publication. Welcome you, sir. We are delighted to have you on board for the class, ma'am and sir. Before we move on to the class, audience are requested to mute their audio and video for the class duration. If there are any queries, kindly do post these in the chat boxes, which will be discussed later. Off to Alka ma'am for the class session.
Thank you very much. I hope your screen is all visible to all of you. Okay. So, good evening, everyone. Today, we will be discussing the approach to the patient with gastrointestinal bleeding in emergency department. The focus of this session will be more towards the ED rather than the anesthesia perspective. And I hope by the end, you will feel more confident in handling with GI bleed patients in emergency situation. So, starting with the case, a 48-year-old man with a long history of alcohol abuse is brought to the emergency department after vomited a large amount of blood. He has no comorbid condition, take no medication. On physical examination, he is drowsy and pale. Patient has a fever. Pulse rate is 120 beats per minute and blood pressure is 85-60 mmHg in supine. Just read these cases carefully because we will begin with the MCQ first. So we have 5 MCQ. For each MCQ, I'm giving the 20 seconds to answer. Just I would like each of you think and vote for the answer. Don't worry if you are unsure, because by the end of this session, I hope you will be answer all the questions confidently in by own. So first question is, what is the most likely cause of his upper GI bleeding? Option is peptic ulcer disease, B is malarious tear, C is esophageal varices, and D is gastric carcinoma. Your time starts now for 20 seconds for this question.
Twenty seconds is up almost.
Okay.
So most of them have gone for esophageal varices, and Amrita has given the first answer.
Great. Next question. After securing the airway and initiating IV access, which of the following is the best next step in initial management? First option is administration IV PPI, bolus followed by the infusion. Second is transfuse PRBC to maintain hemoglobin more than 10 gram per cent. Answer C is insert NJ tube and perform the gastric lavage first. And option 4 is being transfused only if hemoglobin less than 7 gram per cent and continue volume resuscitation with the crystalloid.
We request all the participants to participate in the questionnaire session. The time is up. Most of them, yes, ma'am. Most of them have given like as B, D, and A is also an option here.
Maximum for D they have given.
Question number 3. In suspected varicose bleed, what is the recommended pharmacological sequence before the endoscopic therapy? First option A is PPI, then go for antibiotic, then octreotide. Option B is octreotide, then antibiotics, then urgent endoscopy within 12 hours. Next option is antibiotic, then octreotide, endoscopy after 24 hours. And option D is vasopressin, then beta blocker, and go for the endoscopy.
Maximum has given the answer is B.
Right answer. Next question. During the resuscitation of patients with upper GI bleed, which of the following best predict the need of urgent endoscopy intervention? Option A is burn creatinine ratio less than 10. Option B is GPS more than 5. Option 3 C is Rockwell score less than 2. And option D is stable vital sign after fluids.
We are expecting more answers from the postgraduates. Yes. Try attempting those questions, and end of the session you will get a clear point.
You
So
can
just
choose any
try.
one. You can choose any. It's not a problem, either correct or wrong.
Yes, we have mixed D and C options, ma'am.
Okay, great. Now, question number 5. A patient with variceal bleeding continue to bleed despite endoscopic variceal ligation and octreotide infusion. What is the next best step in management? Option A is repeat endoscopy immediately. B is emergency surgical shunt. C is tips. And fourth is balloon tamponade for 24 hours.
We have only 20 seconds left. So all the postgraduates, yes,
People are
5
going
more
with D,
seconds.
balloon tamponade.
Most of them are going for option D, ma'am.
Okay, thanks. So, there is an updated article on management of upper GI bleeding that published in BMJ in 2022. I am referring to that during this session, so you will also get to learn from the most recent evidence-based guideline. So, first we divide GI bleed. GI bleed divided into 3 parts: upper GI, mid-intestinal, and lower GI bleed. Upper GI means arising from the esophagus, stomach, and the proximal duodenum. Mid-intestinal bleed means arising from the distal duodenum and the ileocecal wall. And lower intestinal bleeding causes from the colon and rectum. In general, we talk about the upper GI bleeding and the lower GI bleeding. The demarcation marking is ligament of Treves. Above the ligament of Treves, it is called as upper GI bleeding, and below it is called as lower GI bleeding. So there are different causes for the upper GI bleeding, like peptic ulcer disease, gastroesophageal varices, erosive esophagitis, Mallory Weiss tear, vascular ectasia, neoplasm, Dilfoyle lesions, or aortoenteric fistula. Among all, peptic ulcer disease and gastroesophageal varices are the most common cause for the upper GI bleeding. And the aortoenteric fistula, it is rare but cannot afford to miss because it is associated with the massive hemorrhage. Among the causes of lower GI bleeding, diverticulosis, angiectasis, hemorrhoids, colitis like IBD, infectious or ischemic, neoplasm, post-polypectomy bleed, or Dilfoyle lesion. Among all, diverticulosis is the most common cause for the lower GI bleeding. So, what is the clinical presentation of GI bleeding patient? Patient may present with a hematemesis, means vomiting of blood. It is maybe fresh or red color, or bright red color, means there is significant bleeding going on. If it is coffee or ground emesis, that there is bleeding but not active bleeding is right now. Next, patient can present with the melena, like passage of black or foul smelling stools. Usually, upper GI is the cause for the melena. Sometimes it is maybe associated with the right colon. Next, coming to the hematochezia. that is passage of bright red blood from the rectum. And finally, occult bleeding, that bleeding not apparent to the patients. So what are the signs and symptoms of the acute GI bleeding? Patient actually may be present with the hypotension, tachycardia, orthostatic changes in blood pressure. Patient angiotube has a blood or coffee ground-like material. Patient pale, like our patient, perioral telangiectasia, skin abnormalities, and the unstable hemodynamics. Okay. So upper GI bleeding patient come to you, the management part divided into 3 stages. First is the pre-endoscopic management, second endoscopic assessment and treatment, and third is the post-endoscopic management. So in every LI patient, resuscitation should follow the similar protocol. That is A, B, C, D, E. A, first is manage the airway and consider need for if intubation, airway adjunct or the suction. B, check for the breathing, give oxygen to maintain the sets 96 more than 96%. C, put a large bore IV access, get blood for the labs and the VBG to assess the hemoglobin, acidosis, and lactate, and start IV fluid for the resuscitation. And D, check for the AVPO, and always check for glucose levels. Many times it is missed, and most of the alcoholic patient with CLD and GI bleed has a low glucose level. And finally, expose and look for the peritonitic abdomen. In general, if there's minor bleeding, vitals are usually normal, and we suspect the blood loss less than 10%. If it is moderate, means there is postural hypotension and loss is around 10 to 20%. If patient come to you with shock, that means there is massive blood loss and loss more around 20 to 25%. It is a table given in ATLS. You should know about the class of hemorrhage. It divided into 4 classes according to the blood loss. Like in class 1, this blood loss is less than 15%. Class 2, it is 15 to 30%. And class 3, it is 31 to 40%. And finally, class 4, that is severe category, and loss is more than 40%. Other parameter like heart rate, blood pressure, pulse pressure, respiratory rate, urine output, or GCS are usually deteriorated in class 3 and 4 cases. Class 1 and class 2 usually normal. There's one more entities parameter is base deficit. It is class 1, it is 0 to minus 2 millicurie per liter. Class 2, it is increase up to minus 2 to minus 6. And class 3, it is minus 6 to minus 10. And in class 4, it is minus 10 or even less. So need of blood product in class 2 and class 3 is there is need of blood product, but massive transfusion protocol should be initiated for the class 4 in severe cases of hemorrhage. So let's go back to our bleeding patient which comes to your ED with hypotensive and tachycardia. So the common question is when should we transfuse blood and how much? Okay. So there are 2 strategies, restrictive and liberal one. Which one best? Which do you think has better outcome? Is a restrictive one, because there is a NAGM studies which shows mortality rate, rate of further bleeding, and overall complication rate is statistically less as compared to the liberal in the cases of restrictive transfusion. So restrictive strategy is superior to the liberal one. So threshold should be based on the underlying condition, hemodynamic status, and marker of the tissue hypoxia. Always consider blood transfusion only if hemoglobin is less than 7 gram%. We all know 1 unit PRBC raise hemoglobin by 1 and hematocrit by the 3%. But always remember that initial hematocrit can be misleading because it is remains same with loss of blood and until equilibrium is occur. And always look for the correct the coagulopathy. And British Society of Gastroenterology varicose guidelines suggest that over transfusion may be as damaging as the under transfusion. So choose blood transfusion wisely and go for the restrictive strategy. It is all about the PRBC. Now come to the other blood factors which have to give it in bleeding patient. So according to recent guideline, platelet should not be transfused if there is no bleeding, even platelet is low. But if there is no bleeding, no need of indication for the platelet transfusion. Only transfuse if it is actively bleeding and platelet count is less than 50,000. For fresh frozen plasma, if PT and APTT is more than 1.5 to the normal, then only give FFP. If patient has fibrinogen level less than 1.5 gram per liter, despite several FFP transfusion, then go for the cryoprecipitate and offer the PCC factors concentrate to patients who are taking warfarin or actively bleeding. There are some risk stratification score. They are needed for identify the patient who are on high risk for the adverse outcome. It helps in determine the disposition, either patient managed or outpatient or the ICU, and may help to guide appropriate timing of endoscopy. So there are numerous risk assessment score for the prognostication of the patient with the upper GI bleeding. The pre-endoscopic scores are pre-endoscopy Rockall, second score is AIM-65, and third is Glasgow-Blatchford score. And for post-endoscopy, there are full Rockall score, CDR-SNI, and PNET. These each score are designed for the defined outcome, so they show different aspect among them. Like GBS score was designed for the need of blood transfusion, endoscopic therapy, and surgical intervention. AIM-65 for the mortality and length of stay in a hospital, and sometimes it also helps in the cost estimation. More recently, ABC score has been developed that predict the mortality in the upper and the lower GI bleeding patients. So this is a study which showing the comparison of prediction of score related to the need of intervention and the 30 days of mortality is showing the GBS score had a highest discriminative ability to predicting the need of hospital-based intervention among all the other score. It is excluded the ABC score. Some information about the Rockall score. It is validated predictor of mortality in patient with the upper GI bleeding. It has a two component. First is clinical and second is endoscopy. That's why it is called as full Rockall or pre-endoscopic Rockall score. So it is a pre-endoscopy Rockall score has a variable of age, shock, and comorbid condition. If score is less than 2, that means there is low mortality. If it is 8 or higher, then mortality is more than 40%. Full Rockall added the two more parameters, the diagnosis after the endoscopy and the major stigmata of recent hemorrhage. Next score is AIM-65. It is a simple risk score that predicts the hospital mortality, length of stay, and cost in the patient with acute upper GI bleeding. It has variable albumin less than 3 gram percent, INR 1.5 more than 1.5, systolic BP is less than 90, alternate mental status, and the age more than 65. If score is more than 2, that considered as a high risk. It is most, next score is Blatchford Glasgow score. It is very important nowadays for the intervention per se. It predicts the need for the endoscopy therapy and it is based on readily available clinical and lab data like blood urea, hemoglobin level. It has for man and woman is a different values. Systolic blood pressure, pulse, melena present or absent, syncope present or absent, hepatic disease present or absent, and cardiac failure present or absent. So according to this score, if it is 0, then patient can be go to home. If it is 0 to 2, the bleeding risk is low and endoscopic needed, but not urgently. It can be done after 1 to 2 days. And if it is score is more than 5, then same day endoscopy is recommended. So FastTech Blatchford score, there's low risk if burn is less than 18 milligram percent, hemoglobin in man is 30, woman is 12, and SVP more than 100 and heart rate less than 100 per minute. It is used acutely, but is not good as the Rockall to predicting overall mortality. It is predict the need of hospital-based intervention. So the Blatchford, it is advised to do Blatchford score at the first assessment because it is for the intervention and full Rockall score after the endoscopy for the saying the mortality of the patient. So according to this score, which patient evaluated as a OPD or which need to be admitted on the emergency or need a ICU care? So if Rockall score is 0 to 2 or Glasgow Blatchford is 0 to 2, that means patient can be managed on the OPD basis. If it is higher the score, patient has chronic alcoholic history, brisk or active bleeding, should be admitted in ED, resuscitate, and can consider for the admission in the ICU. So next score is ABC score. It is new pre-endoscopy risk score based. It has a age, blood test, and comorbid condition. It is shown that ABC score outperformed current score like AIM-65 and Glasgow Blatchford score to predict the mortality in both group, upper GI and lower GI, in both the bleeding. So it has age, blood tests like urea, albumin, creatinine value, comorbid condition like altered mental status, liver cirrhosis, disseminated malignancy, ASA3, or more than 4. If it is more than 8, then 30 days mortality in upper GI bleeding is 25% or more. In lower GI bleeding is 18% and the more. So while dealing with the upper GI bleeding patient or lower GI, coordinate with the multiple consultant like gastroenterology for the endoscopy, IVR for the intervention, and the gastrosurgery. So what is the correct time of endoscopy? It is advisable for the unstable patient first to stabilize patient and go urgently for the endoscopy. If patient is stable, then you can wait for the 24-hour for the endoscopy in upper GI bleeding patients. So urgent endoscopies, when endoscopy done within 2 to 12 hours. Early endoscopy means within 24 hours. But there's RCT, which 516 patient, which is showing there's no major difference in 30 days mortality in both the group. Either do urgent or early endoscopy. Now, coming to the pharmacotherapy, for the bleeding may be non-variceable and variceal bleeding. So first we cover the non-variceal bleeding. So for non-variceal bleeding, we should start the proton pump inhibitor IV, give the 80 mg bolus and followed by the 8 mg per hour drip for the 72 hours. That facilitate the suppress the acid and the facilitate the clot formation and stabilization. Second, when is endoscopy therapy required? 80% bleed spontaneously resolve. Only endoscopic stigmata, like patient is actively bleeding or chances of rebleeding is 90%. If patient is non-bleeding, but there are visible vessels, then chances of rebleeding is 40 to 50%. Then you should go for the major stigmata, then go for endoscopy therapy urgently. There's one more classification for it, that is gold standard for classifying the peptic ulcer. They divided into 3 groups. Group 1, Forest 1 is acute hemorrhage, 2 is sign of descent hemorrhage, and group 3 is lesion without active bleeding. Start with PPI and then start with the endoscopic treatment. Basically, upper GI bleeding for endoscopic treatment, there's 4 pillars. Yeah, either give the injection, either give the thermal coagulation, or mechanical therapy and the topical therapy. So if patient come to you with forest non-variceal bleeding, forest classification 1 to 2B, then give for initial therapy, give the 80 mg of PPI and go for the endoscopy therapy, and followed by the 72 hours 8 mg per hour of PPI infusion. In case of class 2C or 3, give 40 mg of PPI, no endoscopic treatment required, continue with the oral PPIs. And the question is arise when to start feeding. So in case of 1 to 2B, start oral injection after the 24 hour if there is no rebleed. And in case of 2C and 3, you can start early oral feeding. So what to do when endoscopic treatment failed? So if there is chances of rebleeding and there is any doubt to adequate hemostasis in first endoscopy, then go for the repeat endoscopy. Second, if there is major chance of rebleed, then go for the repeat endoscopy as soon as possible. But if patient is unstable, then go for the IVR, and IVR will do the tips to stabilize the bleeding. And if there is no IVR in your department, then go directly to the surgery. So next, after endoscopy, for non-variceal bleeding, for post-endoscopic management should determine the H. pylori status for all ulcer patients and start with the PPI. It is recommended the twice daily dose for the 2 weeks in all the patient with the non-variceal upper GI bleeding. If patient has cardiovascular disease and on low dose aspirin, you should restart as soon as bleeding has resolved. Now coming to the varicose bleeding, it occurs in 1/3 of patients with the cirrhosis. 1/3 initial bleeding episodes are fatal. And among the survivor, 1/3 will be rebleed within 6 weeks. And only 1/3 will survive 1 year or the more. So what is the predictor of large esophageal varices? If patient has a severe Child-Pugh criteria, if platelet count less than 80,000, palpable, there is palpable spleen, and the platelet count versus spleen diameter ratio is less than 1400. It is a recent studies 2024 that mention that ratio. It is highly predictor of large esophageal varices. So, drug intervention in pre-endoscopy for the variceal bleeding. Give the prokinetic drug like erythromycin 250 mg for 30 to 120 minutes before the endoscopy because it improves the gastric mucosa visualization. Tranexamic acid has not recommended for the GI bleeding. Should start PPI with 80 mg bolus and followed by the 8 mg per hour drip for the 72 hours and give antibiotic. In all the variceal bleed should give the antibiotic shot. And current vasoactive drugs like octreotide and terlipressin, current guidelines recommended if there is variceal bleeding, start the vasoactive drug, and the course is usually 2 to 5 days. But it is contraindication include when cardiac or severe vascular diseases are there. Now coming to the esophageal varices, if there is esophageal varices or the gastric varices, if there is esophageal varices, then go for the band ligation. If band ligation has failed and patient is still bleeding, then go for the tips. Okay. For gastric varices, do endoscopy, give endoscopic injection of the glue. Glue is N-butyl to cyanoacrylate, and it is failed or bleeding, yeah, bleeding start, then go for the tips. What is tips? Tips is transjugular intrahepatic portosystemic shunt. It's shunt created by the placing stent between the portal vein and the hepatic vein that reduce the portal pressure and thereby portal hypertension. That may help in decrease the bleeding. One alternative and rescue therapy is Sangstraken Blackmore tube. It has the balloon for the esophageal. This is the esophageal balloon port. This is the gastric balloon port. One is for the RT drainage. This is RT channel for the aspiration opening, and this is RT drainage, and one port for the pulling the weight around 250 to 500 gram weight to pull, create a tension so that bleeding can stop with the pressure. But right now it is not recommended, not used. It is obsolete now. So summarize upper GI bleeding. First, go for the ABCDE. Manage the stabilize first, resuscitate smartly, and risk stratify. After then intervene. Go for the endoscopy if there is active bleeding within 12 hours. If variceal bleeding, esophageal variceal bleeding, go for the ligation. If further bleeding, go for the further endoscopy. If it is failed, then go for the tips. Same for gastric variceal bleeding, go for the glue injection. If it is failed, retry it. If further failed, then go for the tips. And if it is uncontrolled, then go for the tips is contraindicated. Go for the portocaval shunt surgery that considered with the gastrosurgeon. So finally, early resuscitation and supportive measures are critical to reduce the mortality from the GI bleeding. If you remember the ABC scoring system and restrictive transfusion strategy, you will well prepared with the handle with these emergencies. At the start, we begin with the MCQ. I am sure now after today's session, most of you confidently choose the correct answer and explain why. That is the real goal, not just memorize, but understand the reasoning behind the management part of upper GI bleeding. Thank you.
Thank you, ma'am, for your valuable insights. I hope postgraduates would have got an idea on the management of an upper GI bleed. So, any queries? We'll open it for the PGs. If you have any queries, kindly do post it in the chat box. We'll see it and we'll get back again with ma'am and sir. We don't have any queries as of now. So let's move on to the next class on thromboelastography. I welcome Dr. Gokul sir to take the class. Off to you, sir.
Somebody has asked to share the article.
Good evening, everyone. Am I audible, ma'am?
Yes.
Yes, sir.
Just a second. My slides are visible.
Yes, sir.
Yes.
Listen. Yes, sir. Yes.
Just a second. Yeah. So, good evening, everyone. I'm Dr. Gokul, a senior resident from Department of Anesthesia, KMC Manipal. So today my talk is on thromboelastography and its clinical applications. Before going to the topic proper, I would like to begin with the concept of point of care testing. So what do you mean by point of care testing? It is a diagnostic testing done at or near the patient site with the rationale to yield a rapid generation of results, basically to yield a faster turnaround time and making the decision making more easier and faster, widely used in emergency, critical care, and perioperative settings. So, what are the point of care testings that are commonly used? PT, INR, APTT, that we all most of us know about. So our interest for today is the viscoelastic assay that includes thromboelastography and rotational thromboelastometry. So how does it differ from the traditional hemostasis monitoring like PT-INR and the platelet count, D-dimers and all? So these traditional hemostasis monitor are fragmented, assesses the isolated point, whereas the viscoelastic assay gives us a comprehensive, wholesome picture of the clot dynamics. So let us see how it is useful and how it is plays a critical role in the in day-to-day management. So as the name suggests, the viscoelastic assay basically means the transition of a blood from a liquid state to a gel-like state. Gives us an overview of the dynamics of clot development, stabilization, and dissolution. Reflects a in vivo hemostasis. So let us brush some basics before going deep into the tech. So like what makes a clot stable? Yes, after a localized injury, we have a platelet adhering, leads to the tissue factor getting activated, and further coagulation cascade, which eventually leads to the production of thrombin. So thrombin goes into a feedback loop to reach a critical level that is very essential. So if you see this graph over here, the y-axis representing the thrombin generation time and x-axis representing the time, the thrombin generation that in the red is very essential for the clot formation. So the thrombin burst happens specifically at the site of platelets, so not elsewhere to other bodies. So we wanted the focus site to adhere and form the clot, right? To form a stable clot, right? So this precisely starts fibrin formation. So the fibrin formation, further the thrombin converts into a fibrinogen into a fibrin, and it gives us the thickness and density. And the platelet on top of it contracts and gives us the elasticity and the durability. Yes. So in vivo, after a vascular injury, platelet adder, tissue factor releases, coagulation cascade happens, thrombin generates, fibrin forms, and leads to a stable clot. Now, let us see how does it relate this to a tech monitoring. It provides a wholesome visualization of the clot in vitro. So what does it differ? Yes, we don't have the vessel, or we don't have the vessel wall. So a lot of differences there, right? So what we do once we take the blood, so we had a exogenous activator, a coilin or tissue factor, so which directly activates the coagulation cascade, eventually leading to thrombin generation and fibrin formation. But the unique thing that you see here, the platelets is not the initial step in this in vitro. It is a cofactor. So thus, the critical consideration is that platelets in this setup serves as a cofactor, not an initial driver. So in vitro testing of a clotting evaluates the capability of blood components to form a clot. So the drawbacks, yes, we don't have a vessel, integrity of the endothelium or platelet additions or endogenous inhibitors, and hemodynamic forces, the pressure, the shear stress. So these are the things definitely does not mimic as suggested to a vascular environment. But we can give an overview of which component is needed for the management. So let us go to the basic principle of a viscoelastic assay. So it measures the viscoelastic changes in whole blood under a low shear. So the two viscoelastic assays, the TEG, thromboelastography, and the ROTEM, elastometry, rotational elastometry. So both have a different principles, like which for the TEG uses electromechanical, the ROTEM uses optical detection, but the output is the tracing that represents the clot initiation, propagation, strength, and the breakdown. So let us see the basic principle, which is very important for your exam as well. So the basic principle, you have a cup, heated rotating cup, in which the blood is poured into it with the activator. And you see a disposable pin attached to the torsion wire. So once the activator initiates the fibrin, so you can see the formation of the fibrin forming a resistance to the disposable pin and transmitting into the torsion wire, through which it's converted into electrical signal and amplified to generate a tracing. So keeping in this mind, the stationary here is a disposable pin, and the cup is cup is rotating here. Whereas in rotational thromboelastometry, the cup is stationary, and the pin is rotating here, and pin in between the pin you can see a cuvette with the blood over here. So what happens here? The pin rotates in a degree. Sorry, just a second. I'm not. The slides are visible. Sorry.
Yes, your slides are visible. Very
Slides are
clearly
visible.
visible.
Just a second. I'm not able to see my slides. Just a second. I'm sharing once more.
It's okay, they're seen.
Yeah, so just a second, ma'am. I'm not able to see. Just a second. Just a second. Suddenly my slides are not visible. Just a second.
Just minimize once and check.
Yeah, just a second. Yeah. Is it visible now?
Yes.
Yeah, fine.
Yes, it is
So,
visible.
yeah, so that rotational thromboelastometry has a oscillating pin within a stationary blood-filled cuvette. The pin rotates front and forth with a degree of 4.7 degree. So as the clotting begins, the fibrin strand transmits a resistance. This resistance is counteracted by a counter force spring, which is reflected to the mirror, and with the LED light source detector, we are able to get the tracing. So the differences, I think it's a bit clear. The main difference we have to understand is that which is stationary and which is moving between the egg and the rotem. Coming to the tracing. So the tracing for the TEG has two components: clot formation and fibrinolysis. So as we saw initially, to start the coagulation after adding an external activator, to further have the coagulation cascade. So after adding this external activator, you can see a flat line that is basically the coagulation cascade, the time to start the clot formation. So it will 4 to 8 minutes. So once the clot formation happens, the K value is nothing but the time it teaches to form the fixed strength. And the alpha angle is the rate of how much rate the clot is formed. And the MA is nothing but the maximum amplitude, the maximum strength of the clot that constitutes the platelet and fibrin. And the lysis 30 is the fibrinolysis at 30 minutes. So the ROTAM is the phases of the hemostasis are exactly the same, only the terminologies are different. So I'll just skip that and go ahead. So for a reaction time, when it is R intake, the ROTAM it is CT, and most of the things are similar. So we'll just go to an example. So you see the R is just the initiation and the buildup of clot, K value, angle, and the maximum amplitude, and the fibrinolysis at 30 minutes is the breakdown. So let's see some example. Feel free for the PGs to interact. So you can see here the R value is increased, K value is normal within the range, degree is normal, maximum amplitude is normal, and lysis is also normal. So what could be? What is the diagnosis with the TEG? It's a hemorrhagic, it's a hypocoagulable state due to a low clotting factors. So these patients will be benefited with a FFP. Let's see another example. R value is 4.6 normal, K value is normal. You can see the angle decreased, maximum amplitude decreased, and lysis is normal. So this is a hypocoagulable state with a low fibrinogen and low platelet level. So then another one, normal R value, K value is decreased, amplitude is increased, maximum amplitude is again increased. So what could it be? Yes, it is a hypercoagulable state, thrombotic state. So these are some examples. With this understanding, we will go into the real case scenarios and we will try to correlate how a TEG plays an essential role. So these all are real case scenarios from KMC Manipal. So first one, so 57-year-old male with the decompensated liver disease was presented with hematemesis to the emergency medicine, hemodynamically unstable, grade 3 shock on rivaroxaban for portal vein thrombosis, started 6 months back. Coagulations, PT, APTT are all deranged. So what are the key points in this management? Whether the bleeding is due to a rivaroxaban overdose and the transfusion support we have to know. Keeping this case in mind, we will just see a similar case to this. This is also a 53-year-old DCLD, with a grade 3 shock with previous hematemesis, PT, APTT deranged. So both are same. So after doing the TEG for both the patients, a very different picture in both. Yes, you could see in the case one, having the R value decreased and amplitude decreased. This looks the state of thrombotic, so hypercoagulable state, whereas the second case look to be a more of, yes, a hypocoagulable state. Why is it so? Both the disease background is the same, but a different TEG picture. Why? For this understanding, we have to just brush our pathophysiology of coagulopathy in CLD. In CLD, both bleeding and clotting risk coexist. The standard coagulations, PT-INR, often shows an anticoagulation side with prolonged INR, misleading, suggesting a high bleeding risk. But in reality, the compensatory prothrombotic changes you can see the increasing in von Willebrand factor and decreasing the natural anticoagulants that are produced from the liver create a fragile balance. That's why the CLD patients can present with either a varicose bleed or a thrombosis like a port vein thrombosis or deep vein thrombosis. So this understanding is very essential. So for us to have this will make us to go for a whole dynamic assessment of clot rather than looking at the isolated point. Yeah. So the monitoring of, again, the directly acting anticoagulants, the direct oral anticoagulants is a variable and is inconsistent. Dabigatran showed a prolonged APTT and thrombin time. Rivaroxaban also showed a haphazard PT and APTT. So none of these are reliable in guiding in an emergency. This is where a viscoelastic testing like TEG or OTEM adds a real value to it. So we'll see the second case scenario. A 43-year-old alleged RTA, blunt trauma, hypovolemic shock, CT showed a liver laceration, taken for with HP of 3.6, taken for exploratory laparotomy on day 3, and was in ICU with ARDS and AKI, and with 4 cycles of dialysis. Over the course, he went under, had a multiple massive transfusion. So the initial done after 6-point PRBCs and FFPs and platelets and cryo showed a state of, you can see the lysis being very high. So it's a state of hyperfibrinolysis. So after seeing the TEG, the tranexamic acid was advised and the transfusion support according to the hemodynamic was continued. So let us see the next subsequent day TEG. So on day 2, you can see the fibrolysis being more predominant. So seeing with the TEG, we asked to continue the tranexamic acid infusion, 10 mg per kg. And day 3, it is improved better than the day 2. Again, tranexamic acid infusion was continued. And day 5, you can see the normalization. So in a trauma, why it is very important? The trauma illustrates a complex pathophysiological cascade that culminates in trauma-induced coagulopathy and hyperfibrinolytic bleeding. So this leads to a release of tissue plasminogen activator, leading into a hyperfibrinolysis state. So this is very essential for our management. Just a single picture isolated point would definitely miss this hyperfibrinolytic state. And to check for hyperfibrinolysis, D-dimer or fibrin degradation products doesn't add value like TEG. So you can see here the hyperfibrinolytic state where the mortality comes up to 50%, and even in fibrinolysis shutdown, the mortality is high. So we need a balanced fibrinolysis for the good outcome. So going to the case, third case scenario. So a 56-year-old, fever for 7 days, inability to walk, lower limb areflexia, breathing difficulty, admitted in ward, shifted to ICU for mechanical ventilation. Diagnosed to have acute demyelinating polyneuropathy, and was started on a therapeutic plasma exchange, 4 cycles with albumin. Day 3, she had a sepsis. And day 4, patient developed AKA acidosis. So you can see day 3, when the patient had a sepsis, the PT, APTT was deranged, and the treating physician, considering the derangement, gave a 4-point FFP. On day 5, day 6 only the TEG was sent, but the TEG showed a very different picture altogether. It showed a thrombotic picture. This was very essential in the management, after which the low molecular weight heparin was started, seeing the TEG, and it was normalized. Why? Why so? And it was normalized and patient recovered. So the thrombotic state in a DIC, anticoagulation is an appropriate approach. There are reference articles I have attached. So seeing the derangement of PT, APTT alone, we shouldn't go ahead just by transfusing FFP directly. Thus, TIG gives us a whole picture and it definitely aids in the management. So last case, A 35-year-old G2P1L1 with pain abdomen and absent fetal movements, diagnosis of preeclampsia with abruption with IUD. Examination showed us USG showed a suggestion of a uterine bleeding increasing in size. Lab findings, the fibrinogen were very low, 26.7. So you can see TEG showed a decreased maximum amplitude. So hypocoagulable state, either due to a fibrinogen or platelet. So this was the time course of management. After the TEG and the PRBCs, 10 cryos or transfused, and the second TEG was done, and it was normalized. So important takeaway from this case, in pregnancy, the fibrinogen levels normally rise to 4 to 6 as a protective adaptation against bleeding at delivery. But in postpartum hemorrhage, the fibrinogen is often the first factor to fall level below 2 grams, predicting the higher mortality rate. So this highlights the value of early cryoprecipitate and fibrinogen concentrate to stabilize the patient. Hence, the viscoelastic assay plays a pivotal role in patient management, providing a real-time and comprehensive assessment of entire coagulation from clot formation and strength and even the lysis. This allows the clinician to identify the specific issues and coagulation abnormality and prompt a tailored transfusion to the patient and for a safer management of bleeding and thrombotic risk. Thank you. I would like to acknowledge my Dr. Malvika, Professor HOD of Department of Anesthesia, and I would like to thank Ganesh Mohan sir for the case scenarios. Thank you so much. These are my reference.
Thank you so much, sir, for your elaborate session on the thromboelastography. So we request all the postgraduates to have any to post their queries in the chat box. We have our faculties to clear it out. Yes, any queries? So I think we don't have much queries regarding the topic, as a topic was very clear on both the sessions. So they are requesting for the sharing the presentation, ma'am.
Article on GI
Article,
bleed.
yes, ma'am. Article on GI bleed. Gokul sir, there's one person who asked whether we require TEG for all the patients with deranged coagulation.
Not necessary. I don't think all the setup has a take. So it is very useful in scenarios where in CLDs, as I told about the pathophysiologies, and in more specific conditions, it really makes a difference, I feel. So and
Expensive. I think it's very expensive test.
yes, very expensive, ma'am.
So
And each, I think, at one TEG alone, if you're using the older version, TEG 3000 costs around 1,000 for a one thing. If you're using Rotam and all, it's 4,000 per thing. So
4,000.
it's very expensive, and yes.
I think the
Adhuri
next
ma'am
question
has
is also
some,
answered.
Yeah. Thank you, Alka ma'am and Dr. Gokul for your excellent presentations. Now, Dr. Gokul,
Yes, ma'am.
this is for the benefit of the postgraduates. Can you elaborate? Can you tell them the exact differences between traditional test of coagulation and the viscoelastic assays?
So yes, the traditional test, as I said, ma'am, it's just a point. It just sees the isolated point in the whole coagulation as such. The TEG gives us a whole picture from the clot initiation to the propagation until the dissolution.
That means
So
it's a global picture. What you say
global
is a
picture,
global.
yes,
Global.
global picture.
Yeah.
So definitely the traditional, it adds value to it. I won't say we can just neglect the PTINR, APT, and we'll go ahead to this one. So it just adds value. And what our institute follows a goal-based blood transfusion. So we, based on TEG only, even in massive transfusion, the products are assigned. So it definitely reduces the wastage of products and definitely aids in the emergency care and critical care settings.
And it also reduces the transport time. And being
Yes,
point
ma'am.
of care, the results are available very fast, within
Yes,
10
ma'am.
minutes.
Yes, ma'am.
Right?
In Rotem has such that it comes through your, even you can get through phone also. So
Yeah.
the advancements are such that you can interpret immediately once the activate. But for the
Yes.
test to run, the initial clot formation, it takes 4 to 8 minutes.
Yeah.
So, but you can get it through wireless connection also.
Yeah. And one more thing is they say that these viscoelastic assays, since they're point of care and they're interpreted by the clinician, whereas the traditional tests, they go to the lab and they're interpreted by the laboratory technician. So what is
Uh,
your say on this?
No, ma'am. I think when we keep on using on regular basis, I think you will get used to it. Rather than just for the exam sake, once you, I think, clinically get hands to the tag every time, I think you will get the picture. And there are very like guideline based how much to transfuse
Yeah, that's
accordingly.
what. You get a real-time picture. You get a
Yes,
real-time dynamic picture. As a clinician, you're treating the patient and you also yourself are interpreting the changes in the coagulation which are
yes, ma'am.
taking place. You're
Yes,
not
ma'am.
relying on a lab or something for that,
Yes,
right?
ma'am. Yes, ma'am. Yes, ma'am.
Okay. And
Ma'am, one more take.
yeah,
I
ma'am.
think one should go for the platelet PTINR first. If after transfusion it is not regulated, then only go for the ROTEM because it is very expensive. Everyone can afford. Or if it is bleeding subside with the other FFP platelet and other blood product, then ROTEM is the second option. It is
Yes.
not every patient go for the Rotem, but everyone should know when to use Rotem or not.
Yeah. Yes. And the general outlook is that viscoelastic assays are done for major surgeries, transplant, cardiac,
Cardiac
trauma,
surgery,
obstetric. So, ma'am, what would you say? Would you advise
actually,
that
ma'am,
the obstetric units and the trauma centers, the casualties, all these should be equipped with
yes,
viscoelastic assays? Should we buy TEG? What is your opinion on that?
yes, ma'am. Actually we are using in cardiac OT when I am in post in
No,
cardiac.
but
Yes,
coming to the
of
emergency medicine department, the casualties
most
where and the obstetric suites, the labor room where you get hemorrhagic patients, would
I
you
think
say
for
that we should use a TEG
I
there?
think for PPH patient, we should come directly to the ROTEM because it is very less time to go into the sepsis and septic shock and the massive bleeding. So PPH is just recommended to first go for the RETM and actively bleeding patient can go for because patient in trauma patient, they are usually clean patient, just bleeding for the vessels injury. So there is no role of ROTEM is greater than the other parameter. But in case of PPH or OBS patient, it is recommended you should go for the ROTEM first.
Okay, so that means we should buy these viscoelastic thromboelastographs and equip
Ah,
our obstetric suites and our trauma centers,
yeah,
emergency, casualty with all this,
we
right?
have ROTEM in trauma center also, but most widely used in PPH patient, severe bleeding patient in OBS patients.
Yeah, yeah. No, this is into the tertiary medical colleges
Yes,
and other places.
yes, ma'am.
And
But
pretty well.
Dr. Madhuri,
Hmm.
see, whether it's thromboelastography, it was used in the late 90s and is in vogue in early 2000s.
Yes.
Mainly, all these type of tests, we are just concentrating on one, that tag or ROTEM, but there are multitude. It's a battery of many tests which was started in the Western countries. The companies which manufacture this equipment, they always want to milk the things, first of all. You have to highlight them, making them better, look better. But in the clinical sciences, if you see in the rest of the Asian, African countries, if you're going to buy that, that's another way of, draining the entire economy, the ergonomics to the developed world. These are the policy making decisions. In our country, if we go with the obstetric patient, the trauma patients, the load we are having, if we go with the establishment of these, whether in a good corporate hospital also, that will be a direct drain on the economy in the long run. And whether we always say the patient's life, no doubt about there are other factors in which we can always save the patient's life rather than employing these so much costly uh, investigating these equipments. Rather than, I think we are doing more harm than the good when we come to the bulk. You want to establish one, you may suffer on many other things. And this is something I think we have to be very careful. No doubt in a corporate sector when you are going for a bigger surgeries, people can afford it. In the corporate hospital, they set up for the basically benefits only, for the profits only, not for the real, what you can say, truly patient oriented type of investigations. There you can get anything. I think that's feasible also. But in a country like ours, in the entire setups, it's very difficult to set up the things. Look good for theory in our test books, but the PG students should know what are thromboelastography, the rotem, they should know, and they should know how to manage upper GI bleed. They should know all the different methods. They should all know the different situations, scenarios. But ultimately, whatever the decision they have to take, they should be utilizing the resources available in their hand. That will be more important in saving the life of a patient. Because we can't say that we don't have a rotom or a tag that we cannot save a patient. That can never happen. Whatever the resources are at our hands, we should be knowing how to optimally utilize them to go for a betterment of the patients. And that's the, I think, way we are going to have, and even in the coming days also, in the coming years also, these type more tests will come. I'm telling you, definitely more tests will come with the AI also now integrating into the medical field. They will definitely generate more of the investigatory equipments and parameters, which I think going to revolutionize in the next 10 years. But the cost factor will always be there. So traditional methods and other things, whatever the routine we have got, the basics we have got, that is a must in saving the life. And I think we have to weigh the balance actually, balance on either side. As a clinician, as an administrator, as a policy making, as a health administrator, we have to see from all angles. But ultimately, the patient safety is the priority in whatever capacity we can do. So this is all I can understand nowadays. Also, not just EEG, there are other tests also which are coming in vogue in from other specialties. These are because we are dealing with these, so we are just discussing these tests. So everywhere the situation is same in all the medical specialties. That is a fact.
Yeah, I think even the NICE guidelines, they say that TEG is recommended mainly for cardiac surgery, right? For detecting and monitoring coagulation abnormalities.
See, these all policies or guidelines are formed, at which place? In a ASA headquarters, suppose if you go there, how many of the Africans, Asians are taken into formulating these guidelines? How much the other factors are taken into formulating the things? How much other people's narratives or reviews or opinions are taking into formulating the advisories for particularly used in these type of countries? All the basically guidelines are used basically formulated by those people who have never worked in those circumstances where they may not be successful or maybe a failure also. So ideally speaking, it is the confluence of every clinician from every part of the world with who knows their setups better. If you formulate the guidelines, I'm telling you, if you take ISA, Korean Society, African Society, Sri Lankan Society, All these societies, they sit together, one or two representatives who can represent their areas and the resources and everything. Their guidelines will take altogether a different shape. You will get the textbooks already together changed. Here is a monopoly that Western they have the equipment, they have the infrastructure, they have resources, they've got everything. So their guidelines are considered superior. But those guidelines, how much practical they are to implement in our country, that's a big question. They may be setting so many recommendations, and when we apply those recommendations to a country, it's not possible, not feasible, and in doing so, we may be doing harm than the better of the to the patients. So these guidelines, whatever they're proposing, whatever been written, whenever we go as a student, it's a must. A student must be knowing all these guidelines. But when we really apply these guidelines to our setups, we are always in a soup. वो ना इधर के ना उधर के, just like that, this thing, something happens like that many times it happens like that. And you know, there just like Dr. Alka Verma madam was saying, so suppose we have a massive transfusion protocol triggers, how you set up in your own institution. It's very difficult to have that much of caliber of the that much of manpower requirement, resources, everything. But in our own setups we can have a different methods. We can employ our own people. They can whatever in the background of those things requirement, we can train our people to handle such situation in a different way. So all things go in a different manner according to the setups and resources and manpower. I think the classes, both the classes are very good today, and they have done a wonderful job. Short and crisp classes, and I think Madam Alka started on a very T20 basis, starting with the questions first, so that the people should be knowing without knowing the details of what is going to be spoken. So start with the question. That's the best way to start a class, I think. A fast bowler putting a good swing and a bouncer to the candidates. That was the best way to start. I like that way.
There are many questions in the chat box.
One question is, can we use TEG and ROTEM to remove epidurals after liver surgery or when we have sepsis after a major surgery?
So actually, this was the study that we have proposed, me and my HOD. Thing is that whatever the antiplatelet guidelines that are low quality evidence that followed, that doesn't use a global take on all. So we are trying to do like a study on that. Still, it is there's no recommendation to use a viscoelastic for a removal or remove it early, or just it doesn't go against the guidelines as such.
Another question is, given a chance, which is better, either TEG or ROTEM?
Obviously, Rotem is way better because the TEG, what happens is that even any the shift in any movement, or there are a lot of interference in the normal TEG. TEG 3000, but there are the recent one, the TEG 6s that was launched in 2017. It's much more precise. So and the Rotem has a lot of it has a reagent for specific thing. You can do a platelet mapping. You can use a specific reagent for the specific outcome, and it is much more precise, very precise.
Someone is asking for the article that Dr. Alka ma'am showed about the GI bleed.
I will share in a ISA group because here is no option for the sharing the article.
Okay. Thank you, ma'am.
Yes, ma'am.
It is on BMJ 2022 for the upper GI bleeding management emergency.
There's one more question there. Use of TEG for sepsis after major surgery.
Yes, ma'am. That's what I in my scenario, one case scenario, I would have told about the sepsis, how it played a big role in thrombotic DIC, where even with the deranged PT and coagulation, it is recommended to start a low molecular weight heparin, and that eventually led to the good prognosis. So definitely, there is a 2021 critical care article, which I can share that it has suggested viscoelastic assay over traditional PT-INR. So for in critically ill patients.
Any other queries? We request postgraduate to post any other queries in the chat boxes.
There's a very nice remark passed over there that T20 replaced test matches.
No, test matches cannot be replaced. One day can be replaced, test matches cannot be replaced. Test matches are alive everywhere in the world. We love test matches more than the T20s. T20s sometimes we miss. Dr. Mohan Pathak sir has asked मेरा number. Sir, it's available on the website. ISA website. So I think it's a time to felicitate our faculty also. They've done a wonderful work today. Just screen visible?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir, it is visible.
So Dr. Alka, thank you very much for taking a very good topic, short and crisp. And we at National ISA thank you for taking interest and teaching us the upper GI bleed implications, challenges, and solutions.
Thank you so much, sir. Thank you.
Dr. Gokul, good. You did a good job.
Thank you, sir.
So
Thank you so much.
I congratulate you for that.
Thank
And
you, sir. Thank you so much.
I think keep on doing more good classes like this in the coming days also.
Yes, sir. Definitely, sir. Thank you, sir. Thank you so much.
And Deepa Lakshmi, yourself, as well as Nandini. So the screen coordinators are always the best persons we always come with, and they show their confidence. And I think this is the way to build up the future faculty also. So I think this
Thank you.
must be giving the confidence, and tomorrow you can be speaking like Dr. Alka and Dr. Gokul. So that is the way to go forward.
Thank you, sir.
Thank you, sir.
And thanks to Dr. Madhuri, Dr. Nishant, and Dr. Ridhiman. They are always there to help me in these things. And any more query or any suggestion? Yeah, TEG, sir. TEG, though we are, I think, when I was doing PG in 1999, TEG came at that time in the textbooks. That means it was much earlier than which was commonly used in the first half of the 2000 onwards. From the millennium 2K, it was used very commonly in the Western countries. Dr. Madhuri, you want to say something?
Yeah, this regarding the reference values for TEJ, Dr. Gokul.
Yes, ma'am.
Are there any other factors which we have to take into consideration for the reference values of 10? Patient factors.
Like, I'm not able to get your
Are they
question.
the same for all, like age dependent?
No. It is same for the reference values that are the same for everyone, ma'am.
Are they different in the aged or
No,
in the
the
pregnant,
agent, there
something
are a
like
lot of
that?
different agents. So, if at all, if you want to get a rapid
Age.
no, ma'am. No, ma'am. Age doesn't shouldn't, like, it's not a factor. But there are a lot of reagents for rapid TIG to more be specific on the platelet alone, the platelet mapping component. So to just be on the fibrinogen. So there are different components, but there is the reference. Other than that, the reference values are the same.
But the reference values in an obstetric case, baseline values will be definitely different from a non-obstetric case, right?
Yes, ma'am. So that's what, ma'am. The fibrinogen levels for a normal pregnancy itself is a normal values itself will be high. So, but when we do a TEG, that breakdown, the lysis, it will be the same. It won't like the amplitude might be a little bit different, but it shouldn't be much it wouldn't be like drastically different. There is no specific references, ma'am, as far as I know.
Yeah, they say that in an obstetric patient, if the TEG is like normal, like in a non-gravid patient, you should suspect that something is wrong, and the patient is going in for coagulopathy.
Yes.
Mm.
Thank you so much, sir. Can I leave? I'm still in a hospital. I want.
No, we are just leaving, setting the class off now.
Hmm.
So when we turn the class off, we always say long live ISA.
Long live
Long
ICU.
live ISA.
Long live